Our next team presenting, the last team before lunch, is eMDream. Please come and get set up.
Wait, can we go get set up with them? Yeah.
There you go. There you go.
Is that yours?
Okay, so
No, it can be anyone. Right. I So you don't need to keep them every session.
take the video off of this one, so we have enough space for the rest of the day. But not yet.
In fact,
My grandmother.
My uncle.
My grandfather.
My grandfather.
My grandmother.
My uncle.
My grandfather.
all suffer from heart disease. This is indicative of a worldwide problem. In fact, the World Heart Federation estimates that every year, 17 million people die from cardiovascular disease. Now, the main pain point that our customers expressed is simple. Currently, heart disease diagnosis is both ineffective and too expensive. However, we decided to take our validation a step further to ensure that our product truly fit the needs of our end consumer. Out of 357 potential customers we validated with, 319 told us that they knew someone who'd been affected by cardiovascular disease. They also told us something that I learned from my grandfather. With ineffective diagnosis and ineffective screening, we can rarely diagnose heart disease until a heart attack actually occurs. And unfortunately, that's too late. Now, healthcare professionals face a different issue. They told us that they were frustrated about their inability to screen patients for cardiovascular disease, particularly in asymptomatic cases, as current blood tests are expensive and invasive. If they could just detect heart disease in early stages, lifestyle changes and other measures to prevent the progression of disease. So why don't insurance providers cover preventative care for cardiovascular disease? Well, they face a yet different issue. Although laws do exist, like the Affordable Care Act, which mandates that insurance plans cover preventative care, no low-cost, effective cardiovascular screening device exists, making providing preventative care impractical. With all this in mind, we were able to understand the pain points of our customers to help us develop our device. What we came up with is the most portable, cost-effective, easy-to-use device out there today. But it wasn't always this way. This has been a journey spanning several months, countless sleepless nights, and many, many prototypes. When we first began a couple months ago, we were nothing but an online symptom checker for cardiovascular disease. We thought that this would help us solve the problem. Excited, we took our work to Dr. Sergio Fazio at Oregon Health and Science University, and he told us otherwise. The real problem, he said, was that no effective screening method existed for cardiovascular disease. With this feedback, our first major key insight, we radically changed our prototype, designing a device which we plan to sell in retail. then received a multitude of key insights from patients and medical professionals alike. First of all, according to Dr. Ram Prasad Talahali of Case Western Reserve University, our device was difficult to use and crude, so he suggested remodeling it and making it much simpler. Next, we learned that few patients, if any, would purchase our device on retail as we had originally planned, but nearly all of them would purchase our device if we gave it at their standard clinical checkup. With these key insights, we were able to develop something with the potential to revolutionize the world of medicine. So, ladies and gentlemen, it is my honor to present to you the Dream Kit, a simple device that uses your saliva to detect heart disease. And best of all, it's fully functional as we speak.
Using it is very simple. You go to your doctor and hand to the Dream Kit, which Arm is holding it right now. All you have to do is just put saliva into the plastic capsule, mix it with our nanoparticle solution, and then plug it into the device. You then connect the Dream Kit to your computer using a USB cable, and then activate our software. And then our software will assign you a heart score. This is what Will Fritzler is holding up right now. Now let's say your heart score is lower than it should be, indicating the risk of heart disease. You can now take this Dream Kit home so that you can track your own heart health over time. But currently, in the status quo, what happens is that every time you go to a checkup, you get inundated with tests that are often ineffective, especially for asymptomatic cases. Another problem is that the tests that actually work are often burdened with cost. Furthermore, after you leave the clinic, you don't have any contact with your doctor until the next annual checkup. And that's too long. But fortunately, eMDream addresses these problems. As you can see on the right, there are many value propositions that address the pain points of our consumers. So Deepto, can you explain how the science works behind this?
Absolutely, Kunal. As you can see, our device has many different ways it works, but what's the secret behind our device's capabilities? You see, detecting diseases is a matter of detecting chemical and protein signatures in the body called biomarkers. These are tiny particles in the body that are indicative of disease progression. Unfortunately, these tiny particles exist in low concentrations in the body, which is the exact reason the medical industry cannot currently detect these biomarkers non-invasively. What we at eMDream have done is established a new revolutionary system that can detect biomarkers in the saliva. How we do this? This is done by our novel nanoparticle solution that we've developed, which is able to link to biomarkers, establish them into long chains called polymers, and then detect a voltage drop by mixing it, which we can inexpensively measure. When we first started this project, we were only able to develop one biomarker test, which was for 8-OHDG. Soon enough, we found this would not be sufficient due to low specificity towards cardiovascular disease. In the past 3 weeks alone, we've been able to extend this towards 3 more tests for biomarkers, which in total makes our cardiovascular disease test more robust. Our proprietarial process makes us scalable, so that way, in the future, when there's more biomarker developments and competition from other companies, we will still dominate the market. The proof for our technology lies in our own experimental data and literature, which has been proven by many different sources that it's highly effective in diagnosis.
Thank you, Deepto. The eMDream solution consists of a hardware and software component. The hardware package consists of the reusable Dream Kit and the one-time use-only plastic capsules with the novel nanoparticle solution already mixed in. The software includes the desktop version for clinics, as well as the mobile app that patients can use at home, especially in rural areas or in third-world settings. We plan to market this to actual clinics because, as Avik said earlier, consumers are more likely to use this device if given on their annual yearly checkup. Now, what this did to our business model is that we had to pivot from a retail-based system into something that could be incorporated into patient healthcare. The major value proposition of this model is that now we can give beneficial information to both the doctors and patients in a segment that combines both. Now, by selling to clinics, we can better segment the market to address the specific pain points faced by our consumers. But we couldn't do this without the help of Dr. Rob Uniten of Kaiser Permanente, which is a hospital in Oregon. Now, let's talk about our competitive analysis. So as you can see, eMDream possesses many key features that are different than our competitors and can help us gain market share. For example, we have high-speed diagnosis, we have non-invasive procedures, low cost, population-based screening, scalability, tracking over time, and finally, we have a patent which solidifies the barriers to entry for our competitors. 27,750. These are the amount of clinics that we plan to sell in the United States alone. Now, the current market for diagnostic devices is around $6 billion, but it's projected to double within the next decade. What this means for us is that if we can enter the market at the right time, the potential for growth is tremendous. Due to our potential for growth, we've soft-circled a $25,000 investment from investor Ram Prakash, a clinic owner, and we plan to use this investment to do beta testing in his clinic. Now, with the market this size, it is important that we go to our key customers. Our early adopters would be smaller individualized clinics, probably established in 10 years or less, and have 500 hospital beds or less. Those clinics and larger hospitals purchase medical devices through group purchasing organizations, or GPOs for short. GPOs learn about new products through medical trade shows, peer-reviewed medical journals. eMDream plans to be featured in those avenues, along with endorsements through medical professionals. Endorsements that we already have.
Currently, the cost of heart disease tests range to around $2,000, from CT scans to blood tests. But on average, our patients told us they'd only be willing to pay around $100 for a heart disease test. Well, we took that a step further. The Dream Kit costs $8 to manufacture and 2 cents for the nanoparticle solution. This means we can achieve significant markup while still maintaining our price near the target price we validated with our consumers. Based on our research, around 29% of patients will come into their annual checkup at moderate to high risk for cardiovascular disease. And according to our work with Dr. Brigitte Prawowski, they would need 14 tests for consistent monitoring. The remainder of patients who are at low risk will only need 1 test. So on average, we need to supply 5 consumable packages per patient. Based on this, we decided to market our Dream Kit at a price of around $20, and the consumables will be on a much higher margin of around $12. Because we are selling through our medical and clinics, we will be able to push some of the costs to insurance providers. They'll be able to take around 1/3 of the cost, leaving the final cost to patients much lower than the $100 price we initially validated. Specific pricing can also be further established with the GPOs. But it wasn't easy to get here. We explored many different avenues on how to sell our technology, until we finally settled on a business model that we believe would allow us to maintain the highest profits while still keeping our goals close to that of the consumers. At the beginning, we thought that the Dream Kit would be a one-time use device with high markup on the product and low markup on the consumables. Now, our goal was to one day capture 30% of the global market for this industry. But a goal without a plan is just a wish. So we developed a 10-year pro forma to outline our company's major milestones and try to project our future. Now, from our pro forma, we gained some valuable insight. We learned that we would need around $300,000 of initial investment to cover clinical trial costs as well as initial productization. So we began investigating grants, like the Oregon Community Foundation, to try to achieve this initial cost. Based on the market size, we expect significant return on investment for early investors, at around 700% after 5 years. Now, what we see is that we tried to figure out how we would expand our company over the next 10 years. But until the end of 2016, we plan to finish productization and begin clinical trials, so that way we can be ready to go to market. But because the United States and the Northern American markets require large amounts of clinical trials and extensive FDA testing, our go-to market will initially be in India, where there's lower regulations on medical devices. We plan to begin by selling to individualized clinics, like Medicaid in Kolkata. And we already have our first investor. He's willing to buy the Dream Kits, and his name is Ramesh Harur, and he's willing to buy the Dream Kits after we finish CDSCO testing, which is the Indian version of the FDA, and will take around 6 months for our product. After that, 2 years later, we plan to go to the United States market by finishing FDA. And we based this off of our work with Adam Carroll from Amplion, who told us that we would fall into a 510K FDA approval category, low risk, meaning we could finish it in 2 years. From there, we plan to focus marketing in the Pacific Northwest region, starting, of course, with our hometown of Portland, Oregon. There, we've already begun investigating with large hospital chains like Providence and Kaiser, and we've begun learning on how to integrate with their systems. Finally, by 2025, we plan to expand the Dream Kit to include multiple diseases and diversify it. For example, we plan to look at neurodegenerative diseases and many others. And finally, we consulted on our work with Sergio Tanizescu, an economics professor at Lewis and Clark. We realize that pro formas can be largely speculative, but we still believe that there's a significant opportunity to make a very valuable business. But besides the finance, the business, or the problem, at eMDream, we focused on creating our dream team of highly motivated individuals who came together to solve the common goal of saving lives around the world. Avik worked on doing our customer validation, Kunal did our marketing strategies, Deepto and Arnav did our product development, Shahir made our software and mobile applications, and Anish Mysore and Will did our business plan, and finally I worked on projections and cost revenue models. Today, we are poised to control the emerging market of cardiovascular diseases, but don't just take our word for it. We work with a lot of people and we have great support from CEOs and CMOs of companies all the way to PhDs in the medical industry. Because the riskiest thing that we can do for cardiovascular disease patients is maintain the status quo. This has been the ideal in our brand, and today we are proud to say that we made it after this long journey. We are eMDream. This is our mission. This is our dream. Thank you.
So, this question, as part of your patent process here, is that including validation of each scoring algorithm here? Because when I get a score, that's going to likely prompt me to some action. So we won't want to go showing up for medical help if the score was off, right?
Right, so what we plan to do is in those initial clinical trials, we'll be developing our machine learning algorithms, which will essentially take these patients whose data we'll get their biomarker data, and then use that to create the hard score as a percentile score based off the population. So yes, this includes that initial time to validate these algorithms and create them.
So this is supposed to be a substitute for a blood test, is that right?
No, this is actually a pre-screening tool. So what we have is we have a very niche market in that we can give this to everybody at their annual checkups because it's so inexpensive. And then what happens is if they have a hard score that's lower than what it should be, they can go to get further and higher level diagnosis from CT scans or blood tests, which will have even higher accuracy.
You know what? If you can, does this turn up? Okay. If you can give this to everyone, it's not a niche market.
Right, I meant it's a niche market in that it's not going to be competing with existing things like CT scans or blood tests directly.
I heard you use the word patent in this, and can you tell us at what stage that is, or is it through license or whatever?
So currently, we have a provisional patent filed for this. It's actually about to expire. So what we have is we have a lawyer, a patent attorney named Carrie Bradley, who works at Schwabi, which is Michael Williamson. It's and she works with science research patents particularly. So we plan to, after the provisional patent expires, we plan to actually go forward with it.
So you don't really have a patent, you have a provisional thing which just marks the date that you first
right,
came up
and
with
it inhibits anybody else who wants to do the same thing, because we have the first before it expires, we have all that technology.
Okay, and what does the patent speak to?
Okay, so basically it's basically we made three-dimensional polymer nanoparticle network that basically can amplify really small levels of biomarkers like 8-HTG or troponin, as you saw up there. So very small levels of biomarkers basically amplifies it and basically creates a small electrical voltage which we inexpensively measure with our device.
you guys have a pretty big team. What were some of the challenges and disagreements that came with that?
All right, okay, so basically, since it's a large team and it's difficult to manage sometimes, what we did is we always have regular meetings, especially in person. Whenever we had any conflicts, we just simply state our beliefs, go around the table, say what we believe it should be, and then have a team vote. And we were actually able to get a lot done, even with a large team, and it's proven to be very successful so far.
One strategy we also used was the idea of like disagree and commit. Whereas with a team, what the majority decides after hearing everybody's opinions, that's what we're going to move forward with. So everyone, even if they feel that their idea was better or it wasn't decided on, that's the idea that we'll be moving forward with, and they will work their hardest to get that idea done.
So where have you been getting access to the equipment and supplies to do this research?
So originally, this was actually like an independent research project that was eventually developed into eMDream. But how it originally started out was like a general free radical test, which is obviously not very specific, right? But it actually helped in developing the original technology, which was the polymer nanoparticle network. So originally we tested at the University of Oregon, which has TEM, EPR, which is basically this thing called electroparamagnetic resonance that allows you to actually measure effectively kind of the voltage drop and actually specifically quantify the diagnosis accuracy. So if you actually pass that around, that we actually have a whole booklet that covers the research. So we have the University of Oregon, and we also have Oregon State University, who also gave resources for synthesis of the nanoparticles. But actually, this process was also so easy to do that you can actually, with the right resources, do it at home as well. So it's very easy.
So I want to make sure I understand what you guys have done so far. So right now, if someone were to put their saliva in there and you added the solution, what comes out of that? I mean, it sends some information to your computer, and then you guys have software that interprets that information?
Right, exactly. So basically, we mentioned that the unique thing about the nanoparticle is that it's able to amplify really, really small levels to an electrical signal. And that's very unique. Nobody's ever been able to do that before. So if we can actually quantify a detectable voltage, then we can actually interpret that just in our software by maybe like standardizing a set of voltages, making it like a normal distribution, and then we can actually standardize for a whole variety of patients what your heart score is, like just a linear graph. So.
And so those chemicals that you're detecting, they are only present when you have heart disease?
Okay, so actually yes, but also the really hard part about it is that they're present at really low concentrations, right? Like AOHDG, troponin, CRP. A lot of these are actually present during inflammation as well, just generic inflammation. But if you combine them all together, you can create a very robust, very scalable test. And also the one major advantage of the nanoparticle solution is that it's modular. So with the addition of one small reagent, as you heard, in 3 weeks alone, we're able to add 3 more biomarkers. So nobody can actually compete with us because we can continuously add biomarkers, like on a weekly basis. It's that modular.
Is there any thought about how you take this from a pre-screening to maybe integrate the data with the patient's electronic medical records?
Right. Actually, we have a doctor version. You wanna show that? We have a doctor version that actually we have something called correlative analysis, which basically will take like the breath, like standard checkup stuff, and basically we're able to take heart score reading and then.
So basically, this graph shows here the heart score, and over here is the number of years, and over here it shows that at this point, this is a possible point that we would be able to detect with our biomarkers, but conventional methods detect over here when it's too late. And this is a possible progression of a patient over time. So normally you can see the current heart score, but once it reaches a certain threshold based on standardization and some algorithms based on voltage, it will actually be able to detect whether the person has a susceptibility of heart disease. And you can go ahead and look over the same thing on eMDream.
So in terms of what's going to happen in the future, is it just adding additional biomarkers, or is there anything, any other improvements that you're looking to make in the future?
So yeah, the main feature that we're trying to work on right now is like our expansion, is that we're trying to get more biomarkers that after we solidify our cardiovascular test with preferably even more biomarkers that we can detect in our saliva, we'll move on to other types of diseases, as you mentioned before, neurodegenerative diseases and other types of things that are so crucial towards like human health in general.
I would also like to add that it's really scalable because in 3 weeks alone, we were able to add 2 more biomarker tests to really solidify the cardiovascular disease region. So in the same way, we can expand to other diseases as well in a short amount of time.
So these 2 biomarkers that you just added, did you add them because you could, or those are the ones you wanted?
No, actually, according to our customer feedback from clinicians, those biomarkers are actually very difficult to detect. And if we were able to detect those, then we'd actually be a lot better off in detecting heart disease in its earlier stages where it's more curable.
Also, one of the biomarkers specifically we're looking at, troponin, that's actually the current one that's used in blood screening, and a troponin test costs about $45, whereas ours is like, a third of the cost. So that's basically what screening is